Testing.
Good afternoon everyone, and welcome to our webinar on COVID Oximetry at home. My name is Maureen Baker. As you can see, I'm the former chair of the Royal College of GPs, and I'm a GP, clearly. And also, since April, I've been working as an emergency returned practitioner for the NHS 111 COVID Clinical Assessment Service. And so that's also relevant to our discussions today. And I think many of you will have heard, certainly those of us in the UK will have heard over the last few days, that we are currently in the eye of the storm of this pandemic, and we are entering into, or are in, the most dangerous phase of this pandemic. So clearly, this webinar is coming at a really critical time for those of us who want to take forward this initiative. So the webinar today will describe how we can identify and monitor vulnerable patients earlier in the course of the disease. And we'll be able to demonstrate how it's becoming apparent that this initiative could save many lives. We would love you to ask questions on the chat. We'd also love you to answer questions on the chat. So it'd be quite good to have this interactive conversation going on throughout the presentations. And if you would like to tweet, feel free. Please use the hashtag COVID Oximetry. I just want to say too that much of this material is based in England, so we may refer to English structures. However, it should be relevant to colleagues across the UK and possibly internationally also. And I have checked, and you will be able to access the links from outside England, outside the UK. All right then, so we will now move on with our presentations, please. So our first speaker is Gail Allsopp. Gail is a GP and our clinical policy lead at the RCGP, and she's also the newly appointed medical director for East Midlands AHSN. So Gail, please carry on.
Thank you, Maureen. If I could have my first slide, please. I'm delighted to be here. So I first thought I would start by talking about the terminology that we're going to be using today, mainly because over the last few weeks, there's been a second model being developed, which may have caused some confusion. So this webinar is COVID Oximetry at Home. This is a step-up model from primary care, and this is very much centred in primary care. So the patients will all be community diagnosed. They may have self-diagnosed via the criteria and gone off for a test. They may have contacted 111 or CCAS, as Maureen was describing. They may have presented first to their GP or to one of the hot hubs. But essentially, every single patient as part of this programme will be primary or community care based. And the service that is being offered is a supervised patient self-monitoring service. Now, the aim of this is to recognise patients who are at risk of early deterioration, to try and prevent that deterioration and admit them early, as Maureen said, to save lives. But it also will help us do safe admission avoidance. We don't want to be sitting in primary care worried about every single patient or sending every single patient on to A&E for assessment. So the idea of this programme as well is to keep the right people at home, ensuring the right people get the right care in the right place at the right time from a safety point of view. And in terms of treatment, it really is just supportive, the primary care model. There won't be patients on oxygen or dexamethasone, low molecular weight heparin or trial drugs. This really is just supportive treatment with that patient self-monitoring. Next slide, please. The confusion can come with this other model, this secondary care model or a step-down model that has been developed over the last few weeks, really is stepping up at pace. This is secondary care driven, and these are patients who have been through the secondary care process, either in A&E or admitted to a ward, and are safe for supervised early discharge. And this will be run by secondary care with secondary care clinicians in the vast majority of cases. They may actually, in this cohort of patients, be on treatment. They may be discharged on oxygen. They may have some of the important drugs that are now being used for acute COVID-19. But you can see very different from the primary care model that we're discussing today. The slight confusion comes because the virtual ward is being used across both of these developments. And it's really important just to make sure you realise, is this the primary care side or the secondary care side? Some of you in areas where these models are more developed may actually find that the two come under the same governance structure, and that's fantastic if it does. But if it doesn't in your area, that doesn't matter, as long as you know that today we're talking about that primary care model. Next slide, please. So why is this important? And what I want to do is take you back to a patient. And of course, if you look at this clinical presentation, it's a very typical one. We all know very well now about the acute presentation of COVID-19. This is my personal COVID journey. So these are my symptoms. And I just wanted to highlight something about silent hypoxia. So I started off COVID-19, day 1 to 4, the typical shortness of breath and cough, not particularly bad. I was still sort of managing to do everything, felt absolutely fine isolating at home. By day 5, I lost my sense of smell, became more and more tired. And it's only in retrospect that I actually now think back and look at the subconscious behavioural changes that I made as my symptoms progressed. So at this stage, I stopped walking up and down stairs because of the shortness of breath. I came down in the morning, spent the whole day downstairs, and only went up once a day because of that shortness of breath. This progressed, and by day 9, I had that typical burning chest pain that many people get. And again, that subconscious behavioural change, I almost stopped moving around altogether. I sat down all day long, still continued to work because I was still actually feeling incredibly well. But what I found was I was turning my camera off more and more on remote meetings that I was having, because I didn't want people to see me coughing or looking short of breath. Day 11 was a bank holiday Monday, and this is the really interesting day. Despite being a bank holiday, I had a meeting planned to prepare a webinar a little bit like this for care homes. I woke up that morning with increasing shortness of breath, but still felt incredibly well. Certainly far too well to attend A&E, and certainly far too well to call 999. Knowing it was only 24 hours till my GP surgery was open, I decided to wait. And I continued with the planning of the remote webinar. And Alison, who's on the call today, who'll be presenting later, met me really for the first time on that meeting. And I just want to ask Alison what she saw.
Thanks, Gail. And for me as a GP, I'd spoken to Gail very briefly the week before, and we were there planning this webinar. And I knew that Gail had been COVID positive, but that was all. But as I watched her, I became more and more concerned, because although intellectually, Gail, you were able to talk to me, I could see that she'd got tracheal tug and you'd got a respiratory rate of 30. And so quite quickly, our discussion on the content for the webinar changed, because I became really worried with somebody I had never seen before. We'd never met in person. And I was worried about how sick you were. So eventually, when we came off, I told you had to go and present. I sent you lots of texts and emails because I was really concerned that you should be looked at by somebody else, because you evidently didn't realise quite how sick you were.
Thank you. Next slide, please. And I think this is the message that I really want to get across. When Alison spoke to me and said that she thought I was really unwell, I had complete disbelief. I knew I had COVID. I knew I was a little bit unwell, but I didn't think I was that unwell. When I then went on to do my own observations, Alison was absolutely right. I had a respiratory rate of 13. It's very difficult to do your own respiratory rate. So if you haven't heard of an app called R-Rate, it's a fantastic app where you can do your own respiratory rate. You can teach children to do it. You can use it remotely for your patients. My respiratory rate was 30 at rest. I ran up and down stairs and it turned out to be 38, and my heart rate was elevated. But most importantly, my saturation's read at 86%, and I had absolutely no idea that my oxygen had dropped that low. And of course, we now know that if your oxygen level is below 92%, you have almost a 1 in 3 chance of being admitted to ITU and subsequent potential death as well. So I was clearly very unwell, but had no idea. And reflecting on my experience when I was sitting in a hospital ward, one of the things that I realised was that I absolutely needed empowering to go to hospital. And it really was Alison's text messages to me saying, have you gone? How are you? What happened? That really pushed me to go and do that. But silent hypoxia is not obvious, and patients won't have insight in the vast majority. But when somebody tells you your oxygen levels are so low and you're at risk, it's incredibly frightening. But also it can affect your cognition, the way you're interpreting things, the way you're dealing with things, and that subconscious change in behaviour. So I want to hand over to Matt now. Next slide, please. And Matt will talk us through the evidence behind this.
Thank you very much. Do you mind passing on to the next slide? So what an incredible story that really sums up everything to do with COVID, that patients, political commentators, journalists, and the media have noted really since day one. And, you know, what we saw in our cases, we are terrible as a profession at presenting in a timely manner. We all know this, and Gail's story unfortunately mirrors the story from a lot of us who had COVID during first peak. Peston commentated on this story, which was not unusual. We kept seeing people present very late. They didn't present as normal sick people present. A characteristic of this was the absence or paucity of accompanying signal that someone could be sick. So what this is really focusing on is that this prioritization and how we're going to tackle COVID is only limited in regard to what we think about from a hospital and an intensive care perspective, and actually what we do in the community in terms of empowering patients and giving them a voice to go and seek help and monitor and self-monitor and self-escalate is probably the key intervention, and that we have room for improvement. If we look at our case fatality rate during first peak, where our oxygen level threshold for admission was lower than it was in a number of countries around the world, and our case fatality rate may have been as a result of that. And I guess what the wars to come and seeing the rise in numbers of COVID cases and what we learnt from history with Spanish flu in 1918 and what we are seeing in second and potentially third and fourth peaks to come. So this is about that empowerment process and understanding where we really are. Next slide, please. The evidence, I guess, around oxygen saturation was piqued with curiosity with a project that began through a collaboration between the ambulance service, the emergency department, general practitioners, and a hospital within a 500,000 geographical population area. So we studied it. We looked at oxygen levels in the community and then what happened to patients thereafter, producing a paper that, believe it or not, has been read nearly 100,000 times since December. I guess it hit the mark in terms of what we were after in terms of evidence, an early signal as the link between the very simple oxygen saturation recordings and future outcomes. And it made us really reflect on whether we had our thresholds right in this country and whether we needed to raise them. To improve awareness both of oxygen levels, but also the responsiveness of the system they're in. Next slide, please. So in terms of what that evidence showed us, as Gail's slide showed, as soon as you hit the 92% or below mark and you raise the red flag for concern or help from healthcare, you are on about a 1 in 3 trajectory for ending up either dead or on intensive care in an emergency hospital admission within 30 days. So the sooner you present, if you're going to need to come in, the better. And this has been borne out in other further studies, which suggest there's a 1% increase in mortality for every day you do not present if you require a hospital admission. And that's affected our safety netting guidance that's now out to reflect a 92% or lower score should mean you come to the emergency department immediately through your own steam if you can make it, because we haven't got a limitless supply of ambulances. If you're well enough to make it and you have the means, if you don't, then it's a 999 call. And if you're in a 93 to 94% grade, you contact for help. You look for help as a patient, either through 111 services, your GP, or your COVID virtual ward in secondary care. And that normal is defined as being in an oxygen level of 95 to 100. Now, baseline is really important here because not everyone is normal. And knowing that baseline is particularly important if you have chronic respiratory disease. So knowledge of that, documentation of that in GP records, but also empowering patients to tell them what their oxygen levels is really, really critical. Because what we know from the survival curves with oxygen saturations is it's only a small amount of percentage points that lead to a great deal of difference in terms of mortality, emergency admissions, and intensive care admission rates. Next slide, please. So the essence of this clinical strategy has very much been around aligning what we do in terms of assessment of COVID, how we manage it in the community and in hospitals and in the interfaces, how we conduct remote assessments, because that's the new brave world we live in, and how we get truly integrated or build towards truly integrated community, ambulance and hospital systems in due course. The safety netting has to be aligned as well as the clinical criteria and pathways to ensure that we are all speaking the same language and enacting the same management strategies no matter where we work. And we will go on to this concept of what this oximetry at home virtual ward represents in a sec. The digital supporting innovations have been found to be incredibly useful in groups that have taken this on, notably in the primary care sector, the care home sector, and indeed the hospital sector. There is opportunity for development, but the tech should not get in the way of getting these models up and running as soon as possible. Pen and paper and words are enough to get this up and running, and the tech can follow. The evaluation has shown some really exciting stuff, and my wonderful colleague Karen Kirkham is going to go through some of her earlier results in a bit, and then a scale and spread model of how we do this at scale quickly at the speed the NHS has never seen, to replicate the wonderful work GPs have done up and down the country with vaccinations thus far. Next slide, please. In terms of that alignment, we began in the hospital at the emergency department sector and put some lines in the sand based on our evolving evidence around oxygen saturations, exercise tests, and the news score. And then carried that through to exactly the same principles in primary care guidance. And we had the great help of 83 national clinical experts, experienced GPs, arm's length body representatives, academics, and patients to construct a really, I think, quite comprehensive primary care guidance that looked at a combination of symptoms, oxygen saturations, news scores, to give us some lines in the sand around how we escalate patients in community settings, married with the principles of personalized care and shared decision making. Very similar to what we've done in care homes, and then linked to future guidance that's about to come out from the ambulance sector. So we're all singing off the same song sheet. Allied to this are the symptoms we know that count, and the 5 top symptoms that appear to be linked with either death or intensive care admission appear to be breathlessness, severe myalgia, chills or rigors, severe fatigue, or new delirium. And those 5 appear to be the heavy hitters in terms of predicting bad outcomes. What is less predictive of a bad outcome but highly significant in terms of the diagnosis are things like anosmia or less of taste, and having a fever per se or a cough. Next slide, please. These are not absolutes. Gail's already gone through the distinction between the primary care model and the secondary care models, which is really useful. And we have a process of evolution now to determine where we go to with our guidance. This is constant shifting sand as we learn more and more about the evidence. So although this is our current state of play, this is not the final word. And Trish Greenlow and her wonderful team are doing some work with RECAP to hopefully give us more information and evidence in due course about how we should be assessing and monitoring patients with COVID. Next slide, please. In terms of a living, breathing example, I'd love you to see this video now produced by Caroline O'Keefe and the wonderful team in North Hampshire. She's a GP and a terrific colleague who's put this model in place and seen over 2,000 patients since first peak with COVID symptoms. Do you mind starting the video, please?
A system for remotely monitoring high-risk patients with COVID is being rolled out across the south after proving to be a lifesaver. One Hampshire man who contracted the virus says he was rushed into hospital for treatment when the device showed his oxygen level was falling. Chris Harris from Old Basing says without it, his condition could have seriously deteriorated. He's been talking to Steve Humphrey.
That was my sole tester. That was my sole indication that, you know, there was a problem coming. Yes.
It's a simple oxygen monitoring device, and it's making a massive difference to high-risk patients with COVID.
I don't know how bad it would have got, but I'm so glad, because that was an absolute, well, maybe extreme, but a lifesaver.
The retired IT administrator was given the device by his local surgery after testing positive, and he was taken to hospital for treatment when it showed his oxygen levels had fallen.
I was already there before my condition started to worsen, which of course it did do while I was in hospital. So I was ahead of the game, if you like.
The device is being used as it was noticed during the first wave of COVID that some patients were experiencing a drop in oxygen levels with no obvious symptoms.
If we wait until they have symptoms before they go into hospital, their risk of ending up on intensive care is significantly higher. So the sooner we can admit people to hospital and get them on the good treatments we now have, the greater chance they have of getting home and getting home sooner.
Medical teams teach people how to use the device and make regular checks either by phone or via an app.
We see very little likelihood of needing to wind this down before next spring. Obviously, the vaccine is very exciting, but we've got months really before we can assume any form of immunity from that.
Meanwhile, Chris is very grateful he got to hospital early before his condition deteriorated. Steve Humphrey, BBC South Today.
Thank you. So a wonderful example. It does make me reflect actually on our perception of oxygen saturations and levels, because as GPs and doctors, we see the abnormal because that's what's raised to us, and certainly in a hospital environment, without realizing, I suppose, that normal is normal for the vast majority of people. So if we are used to abnormal and being shown abnormal, we don't take the seriousness, I suppose, of a minor deflection of oxygen levels as much as we potentially should. And you know, it does make me reflect, I guess, on the cases I've seen, and the fact that actually a very small deflection of oxygen saturations is incredibly significant if you normally run normal. So in terms of after that confusing diatribe of the what's here, with our inclusion criteria for the COVID Oximetry home or virtual ward pathway, we have our suspected patients that are in the community sitting there with a diagnosis of COVID. And then we have to reflect on who might be suitable for this COVID oximetry at home management. And the number one criteria that's coming out is clinical concern of a GP or a clinician. That is our biggest reason for putting people on the COVID oximetry at home, followed by what we know from evidence, i.e. patients were very unlikely to die or end up in a hospital admission if they were under 65. It was possible, but far higher, greater numbers of people ended up with severe conditions over the age of 65. So 65 or above, having symptoms, a diagnosis of COVID, or being under 65 with risk factors and being on the clinically extremely vulnerable group list, or learning disabilities. And this is where things like BAME status, obesity, serious mental illness come into their own as well. Now, the criteria are going to be refined over time as evidence comes about. And if you are within that criteria and you're put on the COVID virtual ward, then you enter this series of self-monitoring and clear instruction with safety netting about when you should escalate should you end up with severe symptoms. And you are followed up for that 2-week period following the onset of your first symptom to check in on you and ensure you don't deteriorate further with either symptoms or a drop in your oxygen levels. Next slide, please. There's a whole bunch of supporting literature and resources, including safety netting guidance that we can share the links for, that you can print out for 111 guidance, 909 guidance. And when, could you go back one, please? To assist the general public. There is a diary that's printable, there are instructions, and there are animations that have been produced by GPs. Matt Hamilton and team did this in their own time, and it's fantastic. I urge you to have a look at it, and if you like it, share it. It's been translated into all languages as well, and we have purchased a lot of oximeters to support this program now. Multilingual translations are in process. We have apps, and we have a future possibility of interoperable digital systems that are shared for the care of not only COVID, but all conditions across entire healthcare systems. This necessity is the mother of invention, and there is a lot of focus on this right now to develop integrated care systems that will be a system that's fit for purpose. Next slide, please. So in terms of what that looks like, next slide. Thank you. In a scale and spread model, we can look at what we've done in my region, which has been looking after, I guess, the healthcare needs from a COVID perspective of the 500,000 population, and then what that might be, what that might look like regionalised across the 2 million population, covering, instead of 100 care homes, going up to 600 care homes, instead of 1 or 2 community hot hubs, 9. Huge spread of the model along similar lines involving our ambulance service, and then measuring the impact in terms of mortality, admissions, length of stay, and reflecting on I guess, the activity change within the ambulance sector, because we don't want to create a system that creates a noise rather than effective care. And what we have found through our monitoring is that actually the 111999 and CAT2 call rate as a result of implementing this across the population does not appear to have changed. Now, we will be monitoring this in an ongoing fashion to ensure that this stays good, because we cannot have a system that overcalls sickness. We are stretched enough as it is. Next slide, please. And what that means is we will have to get our staffing competencies right, to think about the different stages of triaging, onboarding, referral, monitoring, and have the educational resources that back that up. And the Health Service Journal have put these e-learning resources online with free access for all NHS staff. So I urge you to check them out. Next slide, please. Because we have our opportunity. We have the opportunity to really think about our current situation with all our ambulances queuing, to think about how we get a response to improve the flow across the emergency sector, safe care, and increase, I guess, the effectiveness of our treatments and getting to the right patient within the right time frame to ensure that we optimize the NHS to the best of our abilities and cope with this influx of patients. This is not just about a community solution or a hospital solution on its own. This is about being integrated, joining together and being greater than the sum of our parts. Next slide, please. And although the hospital arm will look at supported discharge, we can only look at what we're doing in primary care and think about that admission avoidance element. To keep the safety and flow going, we have to reflect on the journey we've come to, which has been amazing to witness. From the beginning of December, where we had very low uptake, maybe 10% fully operational systems, and remember that, to where we are today. Next slide, please. And the fact that due to the great efforts within general practice and across the improvement networks and the AHSNs, we're now up to nearly 70% operational systems, with a further 30% starting that process off. So 100% universal uptake across the whole country. Quite staggering stuff, and absolutely not a moment too soon. Because when you get these in place and get them up and running, you not only reduce length of stay, as we found within Manchester, you can improve the discharge rate and the safe non-admission rate to handle entire wards worth, and in this case, 3 wards worth of patients in the home environment, leading to a better, a safer and more effective NHS to cope with everything that COVID has to throw at us. Next, thank you. And I think that's the end.
Thank you, Matt. We'll now move on to Karen Kirkham. Karen is the clinical lead for Dorset Integrated Care System. Karen.
Thank you, and thanks, Matt. I'm just going to spend a few moments talking about what it means to operationalise the oximetry at home model within a local system, and just describe to you a little bit about what some of the research has started to tell us in the last few months. Can you have the next slide, please? So I live and work in Dorset, and some of this is going to be really coming from my own experience of setting up the oximetry at home project in the last 6 to 7 months and operationalising it. I suppose at simplest, this is a clinician to patient interaction, giving them an oximeter and giving them the information to keep them safe. Working at primary care network level brings a scale at which it is much easier to implement this system. And in Dorset, we've actually done it as a whole system. So my county is at a little over 800,000 people. And in about 6 weeks, we operationalised this over the entire county, with patients onboarding from multiple points in the system, from GPs who were assessing patients in hot hubs, pulling through their pillar 2 testing, thinking about how we could onboard from urgent treatment centres, and now they all actively have oximeters and onboard to the same central telehealth hub, using 111, who can also divert, looking at the right time, right care, right place for patients, and also from emergency departments where patients do not need to be admitted, but do need to have some follow-up care. And when we started to talk about this with all of our partners across the system, it became apparent that the more that we could do to help each other as an entire system would help protect our limited resources. I just want to give you some facts about my local system. We are about 7 weeks now into the oximeter service that we have set up. And from a standing start, we were taking on around 20 patients a week. At New Year's Eve, we had 56. This week, we have 270 patients that we're supporting across Dorset with COVID and with serious illness in some cases. We've got a higher than average percentage of patients from BA&E backgrounds, so higher than we would expect. And we've had around a 7% admission rate from our ward, many of whom were patients with silent hypoxia, who actually were unwilling to go in, and it shows the importance of having clinical oversight to make that call, to make sure that those patients go in and have been admitted. Indeed, over last weekend, we're really in the eye of the storm currently. We had 10 admitted in a single weekend from the virtual ward. And so it shows the rapidity at which we've had to stand up the service. In terms of onboarding, it's standard. We have oximeters everywhere. We pull down from the national system, and I know that all CCGs have done that. We have oximeters in multiple sites. We have very clear safety netting information and very clear routes for escalation. It's really improved the way that we have been able to work with acute partners. The quid pro quo is if I can escalate to you quickly and I herald that a patient is coming, I don't want them waiting in an ambulance outside. But what I will do in a reciprocal arrangement is then onboard your patients from ED who you do not need to admit. And so it's starting to create a fantastic working relationship between primary and secondary care teams. Next slide, please. From the beginning, we've been trying to analyse the work that we've been doing. And to that extent, we've been working with UCL partners, with a team under Professor Naomi Phillip, and also with Imperial Healthcare Partners. I can let anyone have the full set of slides, but I've just condensed this into one really. But this is really an approach that maintains patients safely in the right setting. This isn't avoidance admission. This is about making sure that we are looking after people in the right setting, but it is also open to local determination. And one size doesn't fit all in terms of the approach that you take. You need to localize it for your local system. In terms of apps and versus telephone, and as Matt said around whether you just resort to pen and paper, which is absolutely fine, there is a trade-off between high numbers and ability to look after increasing numbers very quickly and inclusivity in terms of digital literacy. And again, it needs to be an individual approach between patient groups and between the clinicians. Coordination between primary and secondary care really facilitates the implementation here. When I first set out on this journey with my local system, what became apparent was that making sure that we had all the stakeholders in the room. We've seen this time and time again when we've done webinars across the Midlands and the North, this real coordination with secondary care leaders involved in the setup of the primary care and community care settings has been really pivotal, and a co-design approach is really, really important. And it also allows you to scale rapidly. But also patient and carer training is key to determining the factors. So there are many patients who will rely on carers, particularly people with learning disability, and the elderly and the dementia will rely on carers. So we do need to make sure that that training is put in place. And a couple of other reflections that came through from the UCL research. Leadership is critical. Clinical leads being there, leading the way, and making sure that they are fully in control of the model that's being implemented is absolutely essential. Daily huddles, just to iron out problems, been found to be really important. And then having commissioning and project support is absolutely essential to get this up and going very quickly. Next slide, please. And then other lessons from the wave one, as we went through in the summer, this was a very positive interaction, both from the terms of, both from the perspective of patients and also from staff. It's a safe intervention. That was really important. The messaging from the Imperial work was that it is a safe method of intervention. That was really important to us when we were starting out on this path. And the mortality in this group, and it is a group with lower acuity, is around 1%. Secondly, as I've described, an app versus telephone versus paper, you just need to do one of those, but do it quickly and make sure it's a safe service with good safety netting. Translation of resources has been absolutely critical, And we need to have a real focus on health inequalities of our system, going out to faith groups, helping people to understand the offer as being critically important. And I think we can do much more in terms of the comms about what it is that we're trying to do in a more widespread way. In terms of implementation, you need to be able to flex your model up and down as the numbers go up and down. We've seen escalating numbers. I'm sure that's happening all over the country in terms of the numbers. Adapt existing workforce. You have to fit this over a 7-day fit, and you need to use the resources that you have already and piggyback this on, because to set up an absolutely independent model is going to be really difficult, and mainstream this quickly. And in terms of resources, you can establish this extremely rapidly, as many of us have done. Once the oximeters are distributed, they often get returned. We don't lose a lot in the system, and work across the systems to get what works best for your local area. And then finally, next slide, please. I've just left a few reflections from those two prime research organisations that are working together. And the first is from Imperial. This is a paper that is in preprint, but it finds that home oximetry monitoring can be a safe pathway for these patients. It indicates increased risk to vulnerable groups and patients with low oxygen saturations, as we've described, and in those enrolled on discharge from hospital. And I also enclose a link to the work of Naomi and her team. And we are undergoing rapid research on a continuing basis through this next phase, so that we can be able to give some more detail as we go forward. Thank you.
Thank you very much, Karen. So we'll now move on to our final speaker this afternoon, who's Dr. Alison Tavaré. Alison, also a GP and clinical lead for the West of England AHSN. Alison, over to you.
Thanks, Maureen. And as you said, I'm a GP in Bristol, but I've also worked with the AHSN for some years and have a special interest in deterioration, which is why I've more recently become the regional clinical lead for COVID oximetry at home. Next slide, please. So what I wanted to do was really explain a little bit about how the AHSN is supporting the NHS in developing COVID oximetry at home. Many of you may not be aware of the AHSN's, the Academic Health Science Network, but there are 15 of them spread across England, and each of them have a patient safety collaborative. And part of the National Commission was to support the implementation of evidence-based practice in health and social care, and particularly identifying and supporting the management of a deteriorating patient. So the AHSNs were very well placed to support the NHS with the rollout of the COVID oximetry at home model. Next slide, please. So that's a bit about the AHSN network, but what can they actually do to support? First of all, a lot of it's really practical. We can share the links later to your local AHSN, but often it's signposting, it's just sharing ideas and practical ideas from the patient safety collaborative teams. But there are also lots of resources, and what I really want to highlight, and I want to thank Jo Murray from Oxford, who's been particularly helpful to developing the FutureNHS collaboration platform. It's got an excellent toolkit, lots of national guidance, lots of resources. A lot of the stuff that Matt's referred to earlier is on there. Things like call scripts. How do you tell call handlers what to say? Another part of that is the National Discussion Forum, which was excellent. So if you don't know what to do, if somebody's not picking up their phone, what suggestions have you got? Somebody will come up with an answer for you. Lots of information on how to get oximeters. And did you know that the volunteer responders will collect and deliver oximeters for you? Really simple solutions. And there are some links there for you to register. And as part of the collaboration platform, there's also the National Learning Network, which is a superb sessions. They were weekly, they're now monthly, lots of chance to learn and discuss. Really great forum for asking questions, and there are recordings on the Future platform if you want to see what's been said before. And alongside that, there are 7 regional clinical leads, some of whom are on this call, and that we're here to help support the rollout. Next slide, please. So that's what we're doing, but actually as part of it, we're also looking at how we can support the pathways going forwards, particularly addressing the more vulnerable groups, as Matt mentioned earlier. And one area that I'm working with is on looking at care homes, working with Adrian Hayter, who's one of the National Clinical Directors, and Health Education England. And we're developing an e-learning tool, very simple, that can be shared, text, links sent to a carer if somebody they're looking after is put onto the COVID Oximetry at home pathway. And that's on my to-do list for this week, so hopefully that will come soon. But in the meantime, there's also Restore 2, which has been recommended by the British Geriatric Society as a way of improving communication between GPs and care homes. And I just wanted to highlight Jackie Vassell, who's a care home manager in South West. And she learned about Restore 2, trained her staff, and when they were hit by COVID, she herself got COVID and was having to manage it from home. Her very stretched staff were able to take observations every day of all the residents, and using that they had virtual ward rounds with Jackie and worked out which of those patients needed to be seen by the GP. So really collaborative and worked very well talking to their GPs. Thank you. Next slide, please. And the other pathway I wanted to just talk about was learning disabilities, which has been alluded to by both Matt and Karen. I was shocked to read the PHE report that somebody with learning disabilities is 6 times more likely to die from COVID and at a younger age. Why this is, we don't know. Could be underlying conditions. Could it be diagnostic overshadowing? Perhaps somebody doesn't get out of bed. It may be they're more tired, or it may be they've got COVID. And then also the communication. How does somebody with communication problems access the NHS 111 or speak to the GP, express concerns? Next slide, please. So very briefly, what I'd like to do is just kind of share some possible approaches to address this. One is easy read information. I've put some links on this slide, but in fact I know that Matt and Tim Strawn, who's also on this call, have developed some easy read information. It was approved yesterday and hopefully we'll be able to share it in the next few days. We also suggest that you actually look at who enters the COVID oximetry at home pathway. Generally it's for people 65 and above, but if somebody's got Downs, they should be entered on the pathway earlier because we know they're at much greater risk. And for others with a learning disability, consider whether the pathway is appropriate. If someone's got mild learning disability and autism, then they can be managed in the community perhaps, but if they've got profound and multiple learning disability, recurrent infections, then perhaps they should be looked after on the ward. Think about reasonable adjustments. Do you need to make more calls? How can you communicate? Are people going to be digitally literate? And then finally, one of the issues, as I mentioned, was communication. And I've been working with the AHSNs and with NHS England Learning Disability team, developing resources to support families and carers when somebody's unwell. So we started it some months away, but it's really opportune. And the programme has been co-produced. It's called Signs Someone May Be Unwell and What Should I Do? Based on Restore 2 Mini. It's free to use, lots of resources, and it's really appropriate for the the community learning disability teams. So that's being rolled out in the next few weeks. And if you know anybody who might be interested in that, please direct them to the leader programme. I've put the email there. So a very quick overview of what's going on, what the AHSNs can do, some ideas of what's coming. So keep an eye on the Future NHS platform, because that's where we're going to be sharing the information. And thank you for listening. I'm going to hand back to Maureen and Gail to take it further. Thank you.
Thank you very much, Alison. So hopefully you've been submitting questions and indeed answering questions on the chat throughout the presentations. I'm now going to pass over to Gail to put some questions to our speakers.
So yeah, thank you so much for all of the chat. It's been excellent, the amount of information that's there, and also some of the conversation that you've had between you. We've got huge numbers of questions. There's a lot of questions around the R-Rate app that I discussed, and it's a fantastic app. It was available on Apple and on Google Play. I've just checked, it does look like it's been taken off the Apple Store, but it is still there on the Google Play side. So if you have an Android phone, you should be able to access it. At the moment, Apple isn't, but what I'll do is I'll look into that and find out why that's been removed from there. It may just be something to do with the updates. Let's move on to a question on safety, if I can. Karen, you talked quite a lot about safety, and there's been a few questions in the chat about that. So firstly, is it really safe to give an oximeter to patients? And what happens if something goes wrong? Who's liable? But when you say in your presentation that it's safe, what did you mean by that? What's the safety that you've measured?
Okay, so great questions. So the first thing is, of course, it's a safe intervention to give someone an oximeter if they understand how to use it and what they're going to do about it. So there is it's not just as simple, obviously, as just giving someone an oximeter. There is quite a process to go through, which is why we've developed the training materials to be sure that the people who are supervising this know what they're doing and give the right information to patients. When I say it's a safe intervention as a concept of the oximetry at home ward, what that meant was there was no greater mortality from doing this. So the last thing you want to be doing is creating harm for patients by giving them a false sense of security, and actually they're really sick at home. So that's really where I said it's a safe intervention, in that it was really important that we didn't see excess mortality from people who were being onboarded onto the oximetry at home ward, because that would be the last thing that we want to do, but we didn't see that.
And the training that you've talked about, that you've developed for staff, and there was a question about patient information. Is there a resource somewhere where all of this is contained so that people aren't reinventing the wheel? Yeah,
I'll probably come to Alison to talk about the AHSN, because and where we host a lot of that material. So what became very apparent very early on was that there was a massive amount of information that was being released and written, and we didn't want people to be recreating. And we also wanted to have the really consistent messages about the safety netting guidance, what was required of staff as they were onboarding, and those competencies were developed by some fantastic nurses in the Wessex AHSN, actually, who put together what they felt were the core competencies to be able to look after patients safely on this ward. So all of those are available through the AHSN sites, and we'll make sure that they are available to you, because just basically through a one-click link, it will get you access not only to the current safety netting guidance, patient leaflets, the competencies that we would expect to happen, and also many of the slides that Matt has given already will be on there. So all of this really important information in a very standardized way is held on the AHSN. But also there is a Futures platform, and Tim may want to come in and talk about the Futures platform and how you can access the information through that as well. So through a number of sources.
Alison, we're going to make that page available on the website when we send things out, aren't we?
Yes, we've got the links to the FutureNHS and also to the AHSN Network, but the Futures one is the one I would particularly highlight. It's been well curated by Joe Murray from Oxford AHSN, and keeping it up to date. There's so much version control.
Okay, thank you. Tim, if I may come to you to ask a question, and this is about access to oximeters. Lots of people saying, how easy is it to get to the oximeters? How widespread are they? Should people be buying their own? And in supported living areas, should people be buying their own? And the reality is, how many have we got?
So thank you, Gail. So we have purchased centrally a large stock of oximeters, which we still have in plentiful supply, which can be drawn down by anybody that requests them through their CCG. So we believe all CCGs do have adequate stocks, but they can be topped up at any time. Within 2 or 3 days, we can get new stocks to anywhere in the country. And we're also distributing them to all hospitals as well, so they're ready for discharge as well. So anybody's got any shortages, I think the email address has been circulated where you can contact the central team and get more.
Thank you. And Matt, coming to you, lots of questions about identifying patients. So some people saying, can we not just have every single person with a positive swab sent to one of these services? If we are going to select patients, what should the criteria be? Is it just over 65s? Is it anybody at risk? Is it the BAME community? How are we going to narrow that down?
Yeah, and it's a really good question. And we are learning as we go along in this journey with COVID, to be quite honest. And although we all have anecdotes of 20-year-olds being admitted to intensive care, some of them dying from COVID, they are pretty rare. And there are many, many more people who do fulfill the age criteria and clinically extremely vulnerable list criteria that are probably our true source. But because I guess we are going through another iteration of data analysis on our deaths, admissions, intensive care, ventilations. We are realigning and repositioning clinical judgment as being the #1 criteria for entry, because we trust our GPs, we trust our clinicians in other areas to make that call based on their experience and what their gut feel is about a patient. In due course, we hope to have something more binary to help those without the years of experience of GPs and senior clinicians in a hospital. But that's going to be our starting point for the time being, whilst we evaluate the impact of BAME, obesity, learning disabilities, and being younger within this criteria.
Okay, thank you. And a question for you, Maureen. Some questions coming in about the 111 service and what patients are told from CCAS. What do you actually tell patients who you're concerned about? Because at the moment, obviously, you don't have direct access into the COVID at home clinic. So what information are you giving to patients, and how then does that journey continue?
So the patients that we have this discussion with are patients that we have we've spoken to, we've decided they're okay to stay at home, clearly. And at the moment, we're considering those over 65, those with comorbidities that put them at risk, or frankly, people we're just concerned about for whatever reason has come up in the call. Now, we haven't got a way to directly refer such patients into COVID at home. So what we do is make a note on the free text of the ad astra, often in block capitals, saying, GP, please consider suitability for COVID at home. Personally, I say to people that in their area, there may be a scheme where they can be given an oximeter. And that they may be contacted about that. At the moment, that's all I think myself and my colleagues can say. But this is the reason why, personally, I think we should be able to directly refer patients into the COVID at home scheme. It's more streamlined, integrated, and frankly, it saves workload at the GP practice end.
Tim, I don't know if you can give any more information on that, because it does seem that it would prevent a delay based on what Maureen said.
Absolutely, and we're really grateful for everybody who's stepped up these services so quickly, and we are learning and trying to iterate and improve processes all the time, particularly the onboarding process. And Maureen raises a really important point, because actually everybody is so busy, particularly in primary care and general practice at the moment with vaccinations. We want to make this as streamlined and as easy and as safe as possible so that nobody slips through the net. So we are actively at the moment looking at how we do put in a system, and it is a technical issue as much as anything to see if we can get those CCAS referrals straight through to the onboarding stage. There is such a variable model across the country. The first step really is just to find out where there are bookable slots or where there are directories of services or DOSs already in place. So we've got a piece of work to identify that, because it is, as I say, it's quite variable. But we would like to, in the spirit of trying to make this as easy as possible for everybody and as safe as possible, I think there's an opportunity for improving the process. So we're actively on with that and can bring back updates in due course.
Fantastic. And then a couple of very practical questions. So baseline saturations, Matt, are they sitting or standing?
Resting is the expression. So I would sit people down for at least a couple of minutes and check their oxygen levels doing nothing.
Okay. And then a question about the patient who presents to you saying my oxygen saturations over the last couple of days have been 89 or 90, but actually when you examine them on the call and when you examine their resting saturations, they're actually in the normal range. What do you do with those patients? Because I think these are often the difficult ones for us, aren't they?
Yeah, I mean, I've had one patient that's, so we've seen hundreds, firstly. We've had one patient that had that story actually, and turned out to be the battery on the oximeter. So worth a battery change just to make sure. But also, I'm just reflecting on in about the 2,000 patients that Caroline and colleagues have seen in North Hampshire, about 100 of them have been referred on during first peak to my trust for the same-day emergency care COVID virtual ward assessments. And of those, about 25% got admitted. So 75% of their saturations improved to a safer range by the end of 24-hour period, essentially, that meant they didn't need to come in, but they did need surveillance and ongoing monitoring. So people do fluctuate, they do get better, and the trend is incredibly useful. So if you've got an oximeter that is showing you a trend and symptoms that go with it, GPs will use their clinical judgment and they'll know what to do. Trends, I love trends, but the first thing is to recheck and make sure the battery is fully operational and the patient is using it in the right manner. All common sense. And
a question about the duration of this program, because some people are saying that they're seeing patients with what's so-called long COVID who are having desaturations as well. Can these patients be referred into your oxygen at home, or are we talking about that acute first few weeks?
It's a really good question. We were doing exploration into how we marry up the acute COVID oximetry at home with long COVID, and lines in the sand are being drawn up. Guidance is being written by NICE to define exactly what the categorization is. Certainly out of the GPs I know that have seen cases like this, they are transitioning naturally the evolution of patients that have extended symptoms into a long COVID type strategy. And patients with long COVID with ongoing breathing difficulty actually find this incredibly useful, because what it gives them is a traffic light based escalation strategy of when to know they are safe and when they should require help. So in some cases, it's cut down the calls onto a GP by about 75%, simply because people are empowered to know when they're okay and when they should worry. And when they make that phone call, suddenly as a GP, you're sitting there with more information than you know what to handle with. More information is always a good thing, I think.
Fantastic. And Alison, a question for you about empowering carers, because it's all very well asking patients who can care for themselves, but what about patients who need caring for? How do we empower them to do the pulse oximetry, particularly in perhaps sheltered living or supported living environments?
Thank you. Well, I mean, part of it's going to be the e-learning package, which I meant to get written by the end of the week. That was my deadline for this morning. But also, we could perhaps put the link in there to the health education videos. So Matt was involved, Wessex AHSN, West of England AHSN, and Health Education England worked together to produce some videos last year. And they were rushed out as a response to COVID. We've had over 170,000 views of videos and 52,000 views of the pulse oximetry video alone. So that's definitely a way of empowering people. We have just updated the set to make them slightly less clinical, because of course we didn't know about COVID when we developed them, but definitely video resources, because we find they're easy to access. They've got closed captions on them, and they're 2 or 3 minutes long, and they're clinically accurate because they've been written by clinicians. So hopefully video content will help, and it's more accurate than others, and you can access them on the Health Education England YouTube channel.
Fantastic. And then just finally, because I'm aware of time before I hand back to Maureen, if you could see the programme develop in a way, just in one sentence for each of you, what would be the ideal for you as the next steps of development? Maybe we'll start with Karen.
It would be to continue the system approach. So it's all about the patient from whatever direction.
So system-wide approach. Thanks. Matt, anything from you?
A truly integrated system between community and hospitals. We need to get rid of the barriers and the artificial silos that have been created over time. This is a true nationwide problem. And with that, we will address inequalities, such as those with learning disabilities, poverty, BAME status, all in one fell swoop.
Maureen, anything from you?
Well, I just really want people to be aware of this, engage with it. It just seems to be a pragmatic approach that can really make a difference to patients, can save lives, can improve morbidity. And, it's something that we could start almost instantaneously if you're not already doing it.
Alison, final words from you.
Thank you. I think one of the things I've actually loved about this has been the collaboration across the whole system, as everybody else has said. And what I'd really like to do is build on that. So we include patients, carers, so everybody's collaborating, because actually we've got the power to make huge changes by all working together, not just in COVID, but in the long term.
And Tim, as the director of this programme, do you think all that's realisable? Is that a direction you could take it in, do you think?
I do, and I've just been absolutely blown away by the enthusiasm, the energy, the commitment of all of these different people working together, and the potential to build out from this is enormous beyond COVID into empowering patients to live and stay well at home using, more and more devices, more and more connectivity, more and more support. I think it's the model for the future, and I'm really excited about it.
Maureen, thank you. I'll hand back to you.
Okay, well, thank you all for your presentations. It's been amazing working with you, really inspiring. I hope that colleagues have really enjoyed and taken on board all the messages. Thank you to those who've contributed questions. I think there will be a considerable ongoing discussion on this topic. You've seen email addresses, you've seen Twitter handles. Feel free to contact people if you need some help. I've had several questions about references. Well, they're in the presentations, and the presentation will be available on the AHSN YouTube channel following this. So thank you very much, everyone. Have a good day, and let's fight the good fight.